the growth hormone and the IGF-1 axis. The GHRH is produced via the hypothalamus, which then regulates via the GHRH receptor the production of growth hormone. Growth hormone secretion is also controlled or modulated by other factors like somatostatin, and then this growth hormone is also produced along with growth hormone binding protein. It then circulates with the growth hormone binding protein to reach its target receptor. What is unique about this growth hormone binding protein? What exactly is the growth hormone binding protein?
The extracellular domain of the
yes.
And what it does, it maintains the growth hormone level in the body. And there is less variability in the...
Is it just a binding protein or does it do beyond that? Yes. So, yeah, binding protein is there for transport, but it is a targeted transport. You can talk it like a chaperone. So, once it binds, it will take the growth hormone to the site of action. And what else it will do? Will the half-life of growth hormone increase? So, in conditions where you have got increased amount of growth hormone and growth hormone binding protein, your half-life will be more. You will have more effect of growth hormone. While if GHBP level is low, your effect of growth hormone will be of shorter duration and the direction will be less. So theoretically, if you treat somebody with growth hormone alone versus GH plus GHBP3, the GHBP1 will do better. But there are not much studies because it's not very easy to do in that regard. So it's not just a simple binding protein, it is also a carrier. And this is unique. So which hormones usually have a binding protein? So peptides have, not the steroids. So steroids, peptides don't need. Peptides basically, will they travel in blood easily or not? So they don't really need a binding protein. So when you have IGF-BP3 or you have GHBP, these are strange, unique things. PTH doesn't have a this thing, FSH, LH, none of them. So it's basically cortisol binding globulin, thyroxine binding globulin, or whatever, it's mainly steroids. So there are two unique hormones, peptide hormones, which have a binding protein, the growth hormone binding protein and the IGF binding protein. Their action is more to modulate the action and guide their action. IGF-BP3 will not let IGF-1 levels to go really up. So if your free IGF-1 goes really up, you may have risk of malignancy. So that's why it sequestrates it for a certain scenario. So now it acts on the liver to produce two important compounds, IGF-1, IGF-BP, and also acid labile substrate, which is ALS, and all three of them will travel in the circulation. And this IGF-BP is now, as I said, is another peptide binding protein, which then carries it to its site of action. The most important site there would be the growth plate, where it will act on the IGF-1 receptor to cause induction of growth, largely the sulfation of the chondroitin. So earlier studies were all about how fast in this chondrocyte the chondroitin is sulfated. That's why this factor of sulfation factor came in. Then people found that this also causes hypoglycemia. And that's why they realized that it acts on the insulin receptor, and that's why it was called as insulin-like growth factor. Unique peptide that it has got a binding protein which is going to carry it forward. And this binding protein is nothing but a extracellular domain of the growth hormone receptor. So it's such an interesting phenomena. So you not only have a growth hormone receptor, they are actually sending their messengers in the blood, okay, come to this site. So it's like you are sending somebody on a fishing and you're putting your net and trying to cling them out. So it's such an interesting phenomena. Tissues which will have growth hormone responsiveness will release these receptors and bring them out. Okay, come here, and then we can start producing growth hormone effect from that regards. This increases the half-life 8 times, from around 11 to 80 minutes, which I talked about. And theoretical studies have shown that if you combine growth hormone with growth hormone binding protein, you will have a better growth which is happening. It's not only acting as a transport factor, it is enhancing the half-life and localizing it to a particular site. That is why it's very, very important from that regards. It is, as I said, a good marker if you have somebody who has growth hormone insensitivity. You have got low IGF-1, your growth hormone levels are high, and it does not respond to giving external growth hormone. The IGF-1 does not rise. You do a GHBP. If the level is low, you can say, okay, this is an extracellular domain deficiency. You get the genetic diagnosis right away at that point of time. There are studies which have shown that if you combine GH with GHBP, you will have a better outcome, but this has not been tried because it will become much more cumbersome in that regard. Now, what type of receptor is growth hormone receptor? Tyrosine kinase receptor. So I think everybody gets confused every time. So tyrosine kinase receptor is IGF-1 and insulin, in which you have an intrinsic factor. So this is like a cytokine, type 1 cytokine receptor. It binds to the external domain, the growth hormone binding protein, as I said, it's the external domain. Once there is a binding, there is one side which is high affinity, the other is a low affinity, they come together, and then you will have a separation of the intracellular domain, and that will allow the exposure for phosphorylation, where you have got the pathway which is the Janus kinase 2 or JAK, along with STAT, which is signal transducer factors, STAT5B, which will be responsible for growth. Now, STAT5B will then go and act on the STAT response element to produce specific genes causing growth. So we always say if you have a peptide hormone, you have a membrane receptor, immediate action. What is the type of action that you're seeing here? So it's a slow reaction. So it again says that many of the steroids are now known to cause membrane effect, and many of the peptides are also known to cause the genomic effect. So this is going to be a slow onset of action from here. Now this steroid response, the STAT responsive element includes number of genes, including IGF-1, which of course is the primary gene. You also produce IGF-BP3 and ALS, which I talked about in the initial graph. You also have many other factors, especially the SHC, which is there, the MAP kinase, and if you remember insulin, you know that MAP kinase also causes growth. So this means this is IGF-1 independent factor. It produces IRS. It allows glucose to enter into the cell. It allows calcium to enter the cell. So it is going to promote an environment which is going to cause cellular growth. So what I'm trying to say is that it's not that every growth promoting effect of growth hormone is because of IGF-1. There are IGF-1 independent effects also, which we can see in this regards. Now, there is also a growth hormone antagonist, pegvisomant, which prevents this dimerization, and this is used in treatment of acromegaly as a second-line agent. Now, when we use pegvisomant in the treatment of acromegaly, what is the problem which may happen? Suppose somebody has a macroadenoma, and that's why it's causing this growth hormone excess. You can't do a surgery because of anatomical location. Somebody suggests pegvisomant. Will you offer it or not? It is an inhibitor of growth hormone action. So if you inhibit that, what will happen to the tumor size? It will increase because the feedback inhibition of growth hormone goes. So it should always be used as a second line agent to a somatostatin receptor ligand. If you block growth hormone production, still you are having this IGF-1 level high, then you use this pegvisomant as a second agent. So this acts like an antagonist in this regards. Now there is a variant of growth hormone receptor, which is the exon 3 deletion, which affects growth hormone sensitivity. And there have been some studies which suggest that you should either measure it to decide about what dose of growth hormone can be given, and this becomes important. Now, if you give somebody growth hormone with growth hormone receptor, will they do better compared to growth hormone alone? And we already said the growth hormone binding protein itself will do a good work. So if you give receptor also, they will do much better effect. Now, once you give growth hormone, you want the effect to be transient. You don't want the growth hormone to continue acting. So there are ways in which you can terminate the effect. And the termination, like many of these G protein 1, include the internalization of the receptor. It says, okay, I have had enough. I don't want to receive any more signal. Second would be there are SOCs, which are suppressors of cytokine signaling. And SOCs are involved in a number of growth disorders, which we'll talk a bit later. So if you have too much SOCs, you will have inhibition of growth, which will happen. Now, they will have multiple effects at STAT5B, at the JAK pathway. Then there is also a protein tyrosine phosphatase and protein inhibitors of activation. So there are multiple ways in which body doesn't want to continue growth. Why would you like this growth to not happen on a continuous basis? If suppose there is continuous growth, what is the harm? The major risk is the cellular growth. It's not just the chondrocyte growth. It's the cells will keep on growing. So cancer risk. You know that individuals who have got acromegaly have a high risk of developing colonic tumors and other problems. So you don't want the growth hormone to continuously work. That's why there are so many mechanisms to stop its effect once its effect is. So to summarize the effect of growth hormone hormone and the entire axis, you have got the growth hormone which acts on the growth hormone receptor to produce IGF-1, which acts on the IGF-1 receptor to increase the growth of proliferative phase. Then you will also have increased numbers. Growth hormone has a direct effect also on the growth hormone receptor to produce IGF-1. It also produces BMP, which causes the growth of the collagen 2 as well in that regards. So overall, it has an increased growth and an anti-apoptotic effect. Now, growth hormone IGF-1 we already discussed. This IGF-1 will bind to the IGF-1 receptor, or it will be more precise to say a type 1 IGF receptor. Why I am saying type 1 IGF receptor is that IGF-1, insulin, and a bit of IGF-2 also binds to that receptor. And binding to that receptor, it will cause increased growth. Growth hormone, however, will also have multiple other effects. It's going to act on the adipocyte to cause lipolysis. That's why individuals who have growth hormone deficiency look plump. They have central obesity, they have got round faces and all the other features of fatty excess. It also has an effect on the kidney. What are the major effects of growth hormone on the kidneys? What do you need for growth? And what grows when you're growing? When you're growing, you need what? You're saying bone is growing, so you need what? And phosphorus. So calcium also, if you really look into that, growth hormone, prolactin and estrogen increase the calcium absorption from the gut. But in the kidneys, growth hormone has a very specific effect of increasing phosphorus absorption. That is why people have used growth hormone in hypophosphatemic rickets, not only to increase growth, but also to increase phosphorus retention. So it's going to cause effect on phosphorus. It's going to have a direct effect on the bone as well, which is independent of the IGF-1. And it is going to affect the liver also to have an effect in terms of glucose levels will go up. So you will have hyperglycemia. So when you talk about treatment with IGF-1 versus treatment with growth hormone, which one will be better? Why?
IGF-1, apart from this, there is also a factor that is directly acting on the.
So growth hormone is having many other effects. It's also increasing IGF-BP. So because of IGF-BP, your free IGF-1 will not go up. Half-life will go up, so the effect will be more. Second, this is causing hyperglycemia. IGF-1 will cause hypoglycemia, which becomes important. Plus, there is also a paracrine effect on the bone as well. So whenever you have got a growth problem and you have option of treating with growth hormone or IGF-1, growth hormone is the treatment of choice. The only indication for IGF-1 treatment is if you have GHD type 1A, wherein you have got antibodies which have developed against growth hormone, which is not working. And second, of course, is genetically proven growth hormone insensitivity. That's the only role of IGF-1. People used to say that IGF-1 would be a better agent. So why don't you use the distal agent rather than growth hormone? But now growth hormone has been found to be more versatile in terms of action which is there. So as I said, growth hormone will have an effect on IGF-1, and this IGF-1 will cause hypoglycemia.